Good morning to everybody. My name is Sabino Scolletta. I am an intensivist of the University Hospital of Siena, and it's a great pleasure to take part to this symposium. And I would like to thank Jean-Louis Vincent for the invitation. I do not have any conflict of interest related to this presentation. And this is my syllabus. I start with the first topic, why to focus on tissue perfusion in patients on VAD. Actually, assessing tissue perfusion in patients on mechanical circulatory support is essential to avoid the low output syndrome, which remains one of the leading causes of death after VAD implantation. Under physiological conditions, oxygen delivery is determined by cardiac output and by arterial content of oxygen. But of course, cardiac output is the main determinant of oxygen delivery. In patients with cardiac assistance, cardiac function is replaced by the VAD. And unfortunately, VAD implantation leads to a complex response in the recipient organism, which is characterized by inflammatory response, coagulation disorders, hemodilution, intravascular sludging, pulseless flow, and increased peripheral resistance. All these factors are responsible for microcirculatory dysfunction and multiple organ failure. What about technology and physiology? There are different types of VAD, and they can be pulsatile, rotary, total artificial heart, and rotary can be either axial or centrifugal. With the pulsatile blood pump, blood is ejected by a mechanical pressure plate, either pneumatically or electrically. With axial flow pump, blood is propelled by impeller blades on a rotor, rotated parallel to blood flow. And with centrifugal blood pump, blood is propelled by centrifugal forces, spinning blood in a circular motion using a rotating disc. And this is the same for miniaturized or paracorporeal centrifugal blood pump, such as ECMO. What about microcirculatory changes? So, how does hemodynamic change with continuous blood flow MCS? As the rotary pump speed increases, the blood systolic pressure does not change so much, while the systolic blood pressure increases, and so does mean arterial pressure. So the final result is that pulse pressure is reduced and the pulsatility is very low. So how can we assess and how does microcirculation change with continuous blood flow VADs? The correction of global hemodynamic parameters by rotary VADs does not always cause a parallel improvement in microcirculatory perfusion of the organs. This is due to the fact that there is the loss of hemodynamic coherence between macro and microcirculation. And this disagreement between macro and microcirculation may determine the inefficiency of targeting higher oxygen delivery. This is due to the fact that macro and microcirculation are under different controls. How to assess tissue perfusion in these patients? These are some surrogates for tissue perfusion: lactate levels, SVO2 or SCVO2, the PCO2 gap, or this with respect to arterial venous oxygen difference, or Mottling score, or capillary refill time. However, each of them has limitations, and in addition, they do not provide direct visualization of microcirculation. The direct visualization of the microcirculation can be assessed by an handheld microscope, which can show on the monitor the microcirculation. Since mechanical circulatory supports are used to obtain improvement of tissue perfusion and microcirculation, the question is, What are the microcirculatory alterations in patients with severe cardiac failure? Actually, the alterations may present with 4 states. The type 1 is the heterogeneous red blood cell flow. The type 1 is a reduction in the oxygen carrying capacity of the microcirculation due to hemodilution. The type 3 is the global stagnation in red blood cell flow in the microcirculation due to arterial vasoconstriction or increased venous pressure. And the type 4 is the increased oxygen diffusion distances due to tissue edema. These are the microcirculations of an healthy patient or a severe heart failure patient. We can see that in severe heart failure patient, we have a reduced vessel density, also we have a sluggish flow, and also we have some areas with no flow. So, can these microcirculatory alterations be reversed and tissue perfusion be improved by mechanical circulatory support? In this study, 10 patients with cardiogenic shock or chronic heart failure were supported by rotary flow circulatory support, and the microcirculation was studied by the SDF, which is the second generation handheld microscope. The microcirculation was assessed 3 times before device implantation, immediately after device implantation, and 1 day after device implantation. And it was found that perfused capillary density, capillary red blood cell velocity, and tissue perfusion index improved and just immediately after device implantation, and they remained stable 1 day after device implantation. So the question is, can pulsatile flow have different impact on microcirculation and tissue perfusion? In this slide, we can observe various flow patterns generated from VAD. And so the higher the pulsatility, the higher the shear stress, and the higher the stimulation of nitric oxide release in the microcirculation, which has a positive impact on the recruitment of additional capillaries. So we would expect a further improvement in microcirculation and tissue perfusion if a pulsatile flow is added to rotary VAD. In this study, 12 patients with acute refractory cardiogenic shock were supported by ECMO and by balloon pump counterpulsation, which create a pseudo-pulsatile blood flow. The ECMO and balloon pump impact on microdynamics and microcirculation was assessed with the SDF, second generation handheld microscope. And at different times, the authors did not find changes in microcirculatory variables, so they found unexpected results. But are these results really unexpected? Patients were evaluated after 6 days on ECMO with a high blood flow, and after several days, patients may have achieved microcirculatory improvement following restoration of blood flow. This is a long-term adaptive mechanism. Also, the balloon pump counterpulsation was interrupted for only 30 minutes, and so a short-term interruption of the balloon pump would not affect microcirculation. And finally, baseline microcirculatory variables were already in the normal range. It means that normal cannot be more normal than normal. But what are the implications of microcirculatory changes on clinical outcome of patients on mechanical circulatory support? In this study, 24 patients with acute refractory cardiogenic shock were supported by venous arterial ECMO. The microcirculation was studied with the third generation device, the IDF, at different stages at different times. And it was shown that in survivors, the microcirculation improved a lot, while microcirculation of non-survivors did not improve. This is very important. Indeed, on the left side, is the microcirculation, sublingual microcirculation of a patient who did not survive. And we can observe the hemodynamic incoherence due to the inefficiency of targeting higher oxygen delivery. On the right side is the microcirculation of a surviving patient, and we can observe the hemodynamic coherence due to the recruitment of microcirculation. This slide shows a microcirculation of a patient of mine at my ICU. The patient was supported by VA ECMO due to cardiac failure, acute cardiac failure. And we can observe as the microcirculatory blood flow is completely dependent on ECMO support. As the pump speed goes up, the microcirculation improves. And we can observe the same in this slide. On the left side is the microcirculation of this patient with the VA ECMO flow at 1 liter per minute. And we can observe the inefficiency of targeting higher oxygen delivery. On the right side is the VA ECMO at 5 liters per minute. We can observe the improvement of microvascular blood flow and the recruitment of additional microvessels at 5 liters. There is the hemodynamic coherence. In conclusion, in patients with mechanical circulatory support, monitoring microcirculatory function is of great importance as it provides relevant information on tissue perfusion. And this is particularly true when it is coupled to monitoring systemic hemodynamic. And finally, the main limitation, unfortunately, to the regular use of handheld microscopes in clinical practice is the lack of clearly defined target values. I thank you very much for your attention.